Dear college, I would like to present this radiological fracture affecting surgical outcome of thoracic lumbar fracture. Some was already mentioned by Professor Salman. Content about introduction, radiology evaluation, goal of surgery, surgical outcome, radiological fracture, in conclusion. This is not, I think we can, radiological evaluation, this also, the goal of surgery is important to restore anatomical integrity and structural stability of the injured spine and providing a biological and biomechanically ideal for facilitating functional recovery. So the goal of surgical treatment first is restoration of anatomy. It's include this in radiological fracture, the alignment, deformity correction, proper reduction, stabilization with and without fusion, or restoration of function. This is a clinical factor already mentioned by Professor Salman, and prevent complication. We will discuss about this. So the poor outcome of unfavorable radiology outcome can be related to a pure clinical outcome due to chronic sustained back pain. Discrepancy of radiological outcome and clinical outcome are often reported. Let's see the goal of surgical treatment, deformity correction. I will mention all the factor, radical factor, which I mentioned in the literature, and we will discuss about vertebral body height, posterior ligament complex, interspinous distance, facet joint pedicles, disc lesions, spinal canal stenosis, displacement, dislocation, and spinal lordosis, kyphosis, prevention and correction. Now I will figure in short about the vertebral body height. You see, this is the anterior, between anterior and posterior compression percentage. And the anterior vertebral body height should be, if more than 50%, it will be progressed to kyphotic. This is how to measure that. And this is AO classification 3 and 4. Let's see the burst, the height is reduced. The McCormick loading also explains before. This is an AO classification type A2, type A1, type A2, A12, and type A13. So compression injury, AO type 2, you see, this is with pincher, coronal, and sagittal. Complete burst in AO A4. Now let's discuss a figure about posterior ligament complex. This is include all the ligament complex. This is assessment of PLC is important because its failure significantly influence the severity of the fracture. First, vertebral translation more than 3.5 millimeter associated with PLC injury regarding interspinous distance. Variation of up to 7 millimeter can be normal, but more than 20% widening, this is a sign of an unstable PLC requiring surgical treatment. CT scan correlate clinically neurological finding with the severity and extension of spinal cord damage on the presence and severity of PLC injury. So the PLC injury is very important. PCLC injury integrity can change treatment to conservative treatment or surgery. It depends on the funding of the MRI. PLC high unstable injury, high unstable associated to neurologic injury makes this surgery inevitable. Like this in O type 2 with suspected PLC injury, also this with interspinous distance. And most reliable indicator, said Focaro et al., vertebral body translation on plain X-ray O type C and focal kyphotic in absence of vertebral body injury. Disrupted PLC component on T1 sagittal MRA, like in this picture clearly. And risk of progression of kyphosis with the AO type A3, A4, and B because of PLC lesion. Now, the interspinous process, percentage of widening of the interspinous distance can be calculated with the following formula. With 20% of the widening being considered a sign of unstable PSA should be confirmed by MRA. Significant interspinous increase more than 7 millimeter, pure osseous failure of the posterior tension. Bilateral subluxation, dislocation fracture, and the disc widening of the disc space anteriorly with or without effusion, and or shear chip fracture from anterior end plates. This is very important for the stability. Hyperextension injury also. Then spinal canal encroachment, as is already said before. In burst fracture, information about degree of canal stenosis should be added. It can be reported as a percentage, although the influence of the degree of stenosis in neurological damage varies between vertebral level, but a sagittal segmental transverse diameter ratio 0.4 minimal 0 is highly associated to neurological injury. You can calculate the canal narrowing by this form, and also displacement of dislocation is an important factor. Displacement of dislocation you can see from the type C of AO, and spinal lordosis, kyphosis, insufficient correction can make a late progression of kyphosis. Kyphosis led to chronic back pain, and that is correction resulted in improvement of clinical symptoms in the post-traumatic kyphosis. This is important for surgical outcome. The target of spinal kyphosis, reasonable correction, accept the alignment, so the cup angle should be below 7 degrees for the reasonable function outcome. If there is a correctional loss after the surgery, cups angle 20 or more, stronger correlation with severe back pain. This is sample, cups more than 10.5 will be unfavorable result of radiological. So this is the statement. First statement is anterior vertebral body height loss more than 50% will lead occurrence or progression of kyphotic. Any correction? Lead to, yes.
Lead to occurrence or progression of kyphotic deformity.
Yes, please. Kyphotic deformity.
Deformity?
Yes.
More than.
Oh, yes, okay. Really? Okay. Number 2. Number 2 is assessment of PLC injury is important because its failure significantly influence the severity of the fracture.
But we are talking about the outcomes, so then radiology and outcomes. So injury of PLC, if detected, may cause a worse outcomes.
Injury
or something like that.
of
What do you
PLC.
think?
I'm sorry.
If detected. If detected.
Okay.
Posterior ligamentum complex.
No, posterior long tension ligament. Posterior.
Posterior ligament.
Interspinous ligament, such thing.
Ligament.
Ligament. Assessment. Should I change that?
Yes, okay.
Detection of injury of posterior longitudinal ligament.
Longitudinal.
Detection of injury of posterior longitudinal ligament. Detection and ligament complex is important. As its failure, we could remove the cause, as its failure significantly influence the outcome. Does it? Okay. The outcome. Full stop. So let's vote on 2.
Posterior ligament, not longitudinal.
Yeah. Okay.
This is without longitudinal.
Or just say as it significantly influences the outcome. As it. Remove the failure as well, please. Good.
Yes, 3.
Do we need to vote on that, Hafid? About this 20% widening of interspinous distance?
Yes, it's mentioned in a review of the. Let's just see. This.
It's just showing that's what Hafiz, do you think we should put this sentence there? Do we need it? We just say assessment because how you assess it, you leave it open. Because it's very difficult to assess. Is this a criteria by somebody, 20% of widening?
Yes, it is a criteria, yes. But always MRI should be done.
Okay, we can vote on it. It's not a problem.
Go back to this. Come back. Step. Slideshow. This number 4. Oh.
Less than 0.4 is highly associated with neurological injury. We can make a more comprehensive statement.
More than 50%.
Burst fractures with, and then take out this transverse diameter ratio. No. Just get sagittal transverse diameter ratio 0.40 and put it up there with, okay, are highly associated with neurological injury and outcome. And then just say transverse canal diameter ratio. Sagittal transverse canal diameter. Remove this, please. No, remove the sentence. And then, that's okay. We can vote on this. Four.
Corpse angle more than 10 degree may predict unfavorable radiological outcome. Unfavorable clinical outcome or poor clinical outcome. Corpse angle more than 10 point, let's add angle on the back. Corpse angle. Yes. Yeah, it may be more than 10 degree. Delete immediately. What? After surgery may predict a poor outcome. Both radiological and clinical. Correction loss more.
Should I remove this?
More than strong correlation with severe back pain. Yes, we can delete the 5.